Hello, everyone, and welcome to the Academy for Eating Disorders webinar titled Neurobiology of Eating Disorders with Dr. Guido Frank. My name is Bethany Blackwell. I am the Marketing and Communications Manager at the Academy for Eating Disorders and your moderator today. If you have any questions or concerns about this webinar, please feel free to reach out directly to me at AED headquarters via email at bblackwell@aedweb.org. You can also reach me by dialing 703-234-4120 in the U.S. and by adding a +1 outside of the U.S. Just a couple of housekeeping items before we get started. All participants are muted with the exception of Dr. Frank and myself. The webinar is scheduled to last for 90 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Frank will begin his presentation, after which he will answer questions from the audience. Please feel free to submit your questions to me during the presentation using the text box on the right hand of your screen. And I will read them to him when the question portion of the webinar begins. Dr. Frank, let's check your volume quickly. If you could just please say a few words, and if a couple of participants can let me know if you can hear him clearly by sending a message in the text box I just mentioned, we will get started.
Good morning, Bethany. Thank you very much for inviting me to this webinar, and thank you everyone for participating and listening.
Great. Thank you everyone for letting us know that the volume level is good. Let's begin by introducing Dr. Frank. For those who don't know him, he is a board-certified adult as well as a child and adolescent psychiatrist. He is an associate professor in psychiatry and neuroscience at the University of Colorado. After medical school at the Ludwig Maximilians University in Munich, Germany, Dr. Frank trained in psychosomatic medicine at the Rosneck Center for Behavioral Medicine in Prien, Germany. This included training in cognitive and behavioral therapy, family therapy, body therapy, hypnotherapy, as well as Feldenkrais therapy. He then joined the Center for Overcoming Problem Eating at the Western Psychiatric Institute and Clinic in Pittsburgh, Pennsylvania, where he trained in neurobiological research in eating disorders. This was followed by residency in adult and then child-adolescent psychiatry at the Western Psychiatric Institute and at the University of California, San Diego. Dr. Frank holds grant funding from the National Institute of Mental Health and from different private foundations. He has received multiple awards from organizations such as the American Academy for Child and Adolescent Psychiatry, the American College of Neuropsychopharmacology, the Society of Biological Psychiatry, as well as the National Institute of Mental Health. So without further ado, Dr. Frank, the audience is yours.
Okay, again, thank you very much for the introduction, and thank you very much to all participants. I have to say one thing, I will ask Bethany to advance the slides because I can't do that from my home machine. So please, the next slide.
Oops, sorry.
So before I go into more detail in studies and research and so forth, I thought I just posed the question, is the biology of the nervous system important in eating disorders to begin with? And maybe tell a little bit about myself. Why do I think to study brain research and brain imaging eating disorders is important? And you already heard that after medical school, I had extensive psychotherapy training. In a way, I'm a psychotherapist at my heart. And afterwards, I got into brain research and psychiatric training. And it's very hard to say what causes an eating disorder or what biological, maybe genetic aspects exist in somebody who will then later develop an eating disorder. But what I'm quite certain about is that at least during the course of an eating disorder, those behaviors have a profound impact on the brain and may change the brain if there hasn't been already a premorbid biological alteration, let's say, that makes you vulnerable to develop an eating disorder. And such changes in the brain, I think, have profound impact on certain circuits in the brain, we call it, such as reward processing, such as emotion processing, thinking, cognitive function. And that's why I think it's really important that we, aside from the therapy part, understanding our patients, that we also understand the neurobiology. What are these mechanisms that might contribute to how we think, how we feel, in order then come up with treatments that support psychotherapy. In general, my perspective on biological treatments is to make psychotherapy better and more successful. Next slide, please. What I hope
Oh, and
you
Dr.
will.
Frank, can I ask you just to speak up a little bit? I think some people are having trouble hearing you.
Okay, so I will speak louder. Is that better? Okay, so let me talk louder. Is this okay? Let's try this. So just to summarize the previous slide, I do think that eating disorders, if not before the illness has started out, for sure during the illness, the brain will change, and this, I believe, has important impact on how we feel, how we think, how we may approach food, having an impact on brain circuits such as the reward system, for instance. And that's why I think it's important to understand the neurobiology, that we come up with treatments that support psychotherapy, biological interventions that I'm hoping for, that then make psychotherapy more successful and make our patients more successful. What I'm hoping that you will get from this webinar today is that you will be able to describe brain research applied to eating disorders, where are we at. Second, that you learn about new research on brain circuits that characterize different disorders, brain circuits that we can relate to particular behaviors. And third, I hope you will get insight how we may be able to use brain biology to determine illness outcome maybe, and maybe develop new treatments. Next slide, please. Next slide, please. So I wasn't sure whether everybody is a specialist and expert in eating disorders or not who is participating in this webinar. So I thought I'd briefly review eating disorders criteria. And for one, we have anorexia nervosa, which is according to our new DSM-5 criteria, characterized by restriction of energy intake relative to requirements, significantly low body weight in the context of age, sex, developmental trajectory, and physical health, and then this intense fear of gaining weight or becoming fat, although people are already very thin, very underweight. And then there is this disturbance in the way one's body weight or shape are experienced, this what's called body image distortion, where folks feel themselves, experience themselves as very fat, again, while they're very underweight. Next slide, please. Then there's bulimia nervosa.
Sorry about that.
Characterized by recurrent episodes of binge eating, a sense of lack of control over eating. Folks just cannot help. They have to eat large amounts of food in a short period of time, and that is paired with a recurrent behavior to prevent weight gain, most commonly self-induced vomiting, but then there are also other behaviors such as use of laxatives, diuretics, fasting, excessive exercise, and so forth. Those behaviors occur at least once a week for 3 months, and self-esteem is tremendously affected by body shape and weight, and those behaviors do not exclusively occur during anorexia nervosa. Next slide. There's the new diagnosis, binge eating disorder, characterized by recurrent episodes of binge eating, just like in bulimia nervosa. However, there are no compensatory behaviors. Those binge eating episodes come with eating much more rapidly than normal. People eat until they feel uncomfortably full. They usually eat when they're not feeling physically hungry. This is very often triggered by high stress, by often feeling difficulty getting everything done, so to speak. The behaviors typically occur alone. Folks eat by themselves, and afterwards they feel disgusted, depressed, and guilty. It's a very, very stressful condition, and I'm very glad that we have this new diagnosis now, because those folks really suffer tremendously. And the behaviors, at least once a week for 3 months, do occur, and they're not associated with another eating disorder. Next slide. Next slide. Thank you. Then there is other specified eating disorders, or OSFED, also a new diagnostic criteria. And I'm also very glad about that one, because there are many folks who have an eating disorder that does not quite meet the diagnostic full criteria of the ones that I just described. Nevertheless, they suffer and they need treatment. So in having this diagnostic category, I think it's much easier for people to get into an eating disorder clinic and get treatment covered by the insurance. Conditions that fall under this category are, for instance, atypical anorexia nervosa, which would be anorexia without meeting, for instance, low weight criteria, or bulimia nervosa or binge eating disorder, where the behaviors have a frequency that's below the once a week for 3 months, for instance. And there's purging disorder, so repeated episodes of purging without any binge eating. And then there's night eating syndrome. Next slide. And another new category is avoidant restrictive food intake disorder, or ARFID, which is characterized by eating or feeding disturbance associated with things like weight loss, nutritional deficiency. Those folks often depend on enteral feedings, a feeding tube, supplements, and it interferes with their psychosocial functioning. The interesting thing is those folks don't really tell you about being afraid of getting fat or things like that, but they tell you, I just don't feel comfortable eating, or they are maybe afraid of swallowing, things like that, but it doesn't really fit a phobic disorder, things like that. So it's a mixed category. It's not better explained by lack of food and not during another eating disorder, and of course not due to a medical condition. Next slide, please. So our understanding of eating disorders has come a long way. You see, anorexia nervosa has a long history being described. There is, in 1689, Richard Morton already described it, and then in the late 1970s, Hillebuch had a psychodynamic model for parents not fulfilling the needs of the infant or a child. On the other hand, there's bulimia nervosa, which has been seen already in ancient Rome, self-induced vomiting to extend eating. And then in 1979, Gerald Russell described it as a variant of anorexia nervosa. None of those descriptions from Hillebuch or Gerald Russell have really panned out as being the explanation. But I think what's true is we can see today eating disorders as very complex psychiatric disorder with a biopsychosocial background. So many aspects contribute to the problem. And what we also have started and continue to find are distinct alterations of brain structure and function. Next slide, please. So brain imaging is the main method that I've been using, and that gives us the opportunity to study the living human brain. And next slide, please. And imaging has come a long way from the single hole camera a long time ago. We can now describe the brain in very interesting formats, in pictures that tell us about brain structure, as you see on the right upper hand corner, a magnetic resonance image. And then right below, you see those colorful images where we can measure neurotransmitter receptors in the brain, or where we can measure pathways, where we can look at very fine connections between all these brain regions. So we have made tremendous advancements in this field. And we have come eventually from sort of the brain as a black box model, where we don't really know what's happening, to now a circuitry model. That means we had in mind at some point that different regions in the brain that do different things, that are important for different aspects of behavior. Where we're at now is that we think about circuitry, about different regions connecting with each other, and then by their activity strength, maybe by the rhythm, how often they connect, then come up with a specific circuitry between regions that then code behavior. Next slide, please. How does it work with brain imaging that we understand the brain? So we start with the illness or the disorder, We have to define it very well. We want to be very specific with behaviors, and we get to that in a moment. And then we do our brain imaging part, structural, functional brain imaging. And then we try to correlate, as the most simple form of analysis, specific behaviors with specific brain results. So when we think about structural imaging, where we look at, let's say, gray matter structure, and we measure certain volume, is maybe the volume in a part of the frontal brain related to the experience of body image distortion or drive for thinness or things like that, or maybe to the frequency of binging or purging. Next slide. So let's go to identifying specific illness-related behaviors. Next slide. For this type of research, it's really important that we make small slices of behavior, that we are very specific what we want to know and what we want to study. So one aspect would be, for instance, self-starvation. Sort of from a psychotherapeutic standpoint, I would think about ability to withstand hunger, right? From actually psychotherapy and a biological standpoint. And there's binge eating. You could translate that into loss of control. Purging, you could think about taking back control. Body image distortion, feeling unrealistically fat. So some people lose contact with reality even in this context. There's high rigidity, resistance to change, low mood, self-worth dependent on weight. There's the symptom instability. You know that folks often go from anorexia nervosa to bulimia nervosa and back, but not all of them. So there's a certain subgroup of those folks. And then there's high anxiety that we often find. Next slide. And now we can relate those behaviors to particular circuits. There are, for instance, brain circuits that regulate eating, that include, for instance, an area in the brain that's called the insula. That's actually the area where our first conscious taste perception is. So let's say you have your morning bagel, let's say, that's where you taste this morning bagel. But then there's these other connected regions like the anterior cingulate, the ventral striatum, the orbital frontal cortex, that then build this circuitry, this network that builds a feedback mechanism. You taste something and then you say that tastes good, I want more, maybe I shouldn't have as much, things like that. So there's a lot of behaviors, a lot of thoughts, a lot of emotions that go into that behavior, and that's processed within that circuitry. Then there are circuits that regulate body image. The insula is part of it. The insula integrates your sensation of where you're in space, for instance, but also the parietal cortex is important. So they work together in that context. Then there are circuits that regulate behavior, control, and flexibility. So where this rigidity comes in, for instance, and decision making. The prefrontal cortex and the anterior cingulate are particularly important here. Then there are brain circuits that regulate mood, whether you feel more sad or more happy, whether you're maybe also more anxious or less anxious. The prefrontal cortex, the amygdala, and the ventral striatum, they interact with each other and they control each other in this pattern of behavior. And then there are brain circuits that regulate fear response. Again, the amygdala, the anterior cingulate, the prefrontal cortex. For instance, in that context, the amygdala is sensitive to what's happening in the environment and might send an alarm signal. And then the prefrontal cortex responds to that and says, oh my God, this is really dangerous and I should get out of that. Or the prefrontal cortex says, well, it's not quite as bad as it seems, so tone it down, amygdala. So there's this back and forth between these regions to control each other. And you can imagine that even only one of the regions involved in a particular circuitry is different than sort of normal biology would expect, then you may have a dysfunction of some sort in that circuitry. Next slide. I do have to say with the within slide changes, it doesn't seem to come out, Bethany. So it seems like the slide comes up and there are not the steps within a slide.
Okay, I'll work on that and see what I can do.
So In the context of neurobiology and how can we tease apart behaviors and disorders based on neurobiology, there's an aspect that always strikes me, and that is there's a person who is maybe traumatized, who has maybe lifelong body image problems, and then eventually develops an eating disorder. On the other hand, there is the person who did always pretty well, but then maybe in middle school wanted to get better in soccer, practiced more over summer, lost a little bit of weight, and then 3 months later also has anorexia nervosa. Or the kids who go to healthy eating class in school and take it really seriously, want to do a really good job, and then all of a sudden they have an eating disorder. So what brain imaging and brain research I'm hoping will tell us eventually is, what do those folks have all in common? What is the biological ingredient that you need to develop anorexia nervosa under certain circumstances? And on the other hand, what are the aspects that separates them, right? The trauma part, anxiety, things like that. So that's what I'm hoping for we learn. And eventually what I'm hoping is that we can understand a person based on those different aspects of biology, and not just think about biologic interventions, but if somebody is particularly, let's say, has an anxious part to it, that we then focus our therapy, our treatment towards these parts, because we can certainly change biology also by therapeutic psychotherapy interventions. Next slide. What are brain imaging modalities? Very brief review. Roughly, we can distinguish structural brain imaging from functional brain imaging. Structural brain imaging gives us a snapshot of brain structure. We could also look at it as volume of gray matter and white matter. Functional brain imaging lets us look at dynamic processes. Lets us look at blood flow in the brain. It lets us look at water movement along white matter tracts, for instance. It also tells about neurotransmitter receptors, how the receptors take on the neurotransmitter or not. So these are the main distinctions. Next slide. So let's get into research results, brain imaging studies in individuals with eating disorders. And those are usually compared to healthy controls. Next slide. Let's start with neurotransmitter receptors. You know that there are these nerve connections within the brain, the synapse that's in between one nerve ending and the other. There's the presynaptic nerve where a neurotransmitter such as serotonin, for instance, is spit out. It travels to the other side of the synapse, and then you see these little half circles on the receptor side end, and that's where the serotonin rocks on. So these are the docking stations for brain chemicals. And when I talk about brain neurotransmitter receptors, then I talk about measuring availability of those receptor sites, of those docking stations. So how many of these places are around or available where the neurotransmitter can latch on, so to speak. Next slide. There have been various studies done using serotonin receptors, and specifically for the 1A and the 2A receptor. And overall, the studies are not very many, but they are relatively consistent. And that is in anorexia nervosa, there seems to be an elevation of the serotonin 1A receptor. The same for bulimia nervosa. There's an elevation of the serotonin 1A receptor in the brain compared to healthy controls. On the other hand, the serotonin 2A receptor is in most studies lower in anorexia nervosa, ill and recovered, compared to healthy controls. So it's always hard to nicely correlate those brain findings with behavior, but what has been shown over and over is that anxiety specifically trait anxiety measures and harm avoidance, they correlated with those serotonin receptor numbers, let's call it, availability of those receptors. So we think that serotonin has an important takes an important part in anxiety processing in eating disorders. Next slide. There have been some studies done in dopamine, using dopamine receptor ligands and cannabis receptor ligands. And the studies are very inconsistent, to make it short. And I cannot really say with good conscience whether they're elevated or reduced in eating disorders compared to controls. However, what it does seem to be the case that the state of illness has an impact on the receptor availability. So when you're ill, when you food restrict, you binge and purge, that probably has an impact on how many receptors there are. And that then changes again with recovery, although we don't know whether the recovered state is a reflection of what the brain looked like before starting the illness, or whether it creates a scar that somebody then has to live with or work with, so to speak, when they're recovered. Next slide. So let's look at brain gray matter volume, brain structure studies. Next slide. What we use here is a main method is using magnetic resonance imaging, these big machines that create a magnetic field, and this magnetic field excites protons in water, in tissue. And every tissue in the brain has a different amount of water. So these protons in the water are excited differently. And just because of the difference in water and this different excitement, we can then get these pretty pictures like the one on the right lower hand corner, where you can quite nicely distinguish brain structures. Next slide. For the longest time, it has seemed that gray matter is lower in anorexia nervosa compared to healthy controls. But then over the years, various research was done, and the results were not very consistent. In fact, there were various higher or lower brain volumes found across the studies. And what I think is part of the problem is that the studies were done under very different conditions. So some studies investigated folks who had been in treatment for a while. Some studies recruited people who were very actively binging, purging, food restricting. And I thought that probably has an impact on how well these studies correlate. And then in 2013, we studied folks in very controlled conditions. So they were all with for a week or two in a highly structured program. We knew exactly how much they were eating, drinking, and so forth. And there we found actually then all of a sudden a very consistent pattern that is part of the brain between the eyes in this middle picture was larger in anorexia, bulimia, in anorexia after recovery, and then on the side, on the picture to the left in the middle, you see these two yellow blobs. The insula was somewhat bigger. So that was pretty consistent across these different individual groups. And then there's research that came out that supported the idea that short-term nutritional status, binge eating, purging behaviors have important impact on brain volume results, and that there are probably short-term effects from those behaviors, and they recover pretty quickly with nutritional rehabilitation, but there are probably also other effects or other factors that are persistent and that might be more involved in behavior. And there are greater and smaller regional volumes to be found, or higher or lower cortical thickness, as it is called. So that brought up the question, what causes eating disorders and what do they cause? So we have to be very careful in brain research and eating disorders that we tease apart effects from the illness versus aspects of brain function that in the other direction contribute to illness behavior. Next slide. Let's look at white matter fibers. Next slide. So you see left upper hand corner a figure of the brain. You see the white matter, and then to the right you see an MRI image, what the white matter looks like in real life, in a real person. And then on the right lower hand corner, you see how with specific methods we can visualize very nicely those fibers. So you can see how those white matters that look whitish on the MRI image, then you can connect with each other and even get them in different colors that tell you about different regions where they occur. Next slide. We also use magnetic resonance imaging, but in a different way. And how we measure these white matter tracts is we essentially look at water movement along white matter tracts. That's how it really works. And there are two different things we can measure in this white matter research. One is called fractional anisotropy. This measures how much the water moves along the white matter tract. And if you think about the white matter tract as a hose or a tube, you want to have the water along the tract. Because if the water goes away from the tract, that would mean you have sort of holes in your tube. And you don't want that, right? So you want to have a nicely insulated nerve tract. So people have then thought about this measure as a measure for fiber quality. So how well these fibers are insulated. Although there have also been some question whether it's really fiber quality or not. But it is probably a reflection of insulation of the fiber and how well those fibers are. It's called myelinated. And the second measure we can get from it is connectivity strength, which is a reflection of number of fibers. How many fibers connect from one area to another? Next slide, please. When we take together the body of literature on white matter studies, then the truth is the studies are pretty inconsistent, but the truth is also the studies have been few. However, what most studies show is that FA, fractional anisotropy, this measure for quality of fibers, is lower in individuals who have anorexia or bulimia nervosa. Although at this point we're uncertain about the functional significance of that finding or the mechanism why it comes about. Next slide. Now, we studied fiber connectivity, so how many fibers there are connecting different regions, in women recovered from anorexia nervosa a little while ago. And we took various brain regions. So one was the insula that you see in yellow, orange, and red. And then look at the connections to frontal cortex, so the orbital frontal cortex, as well as the anterior ventral stratum. And you may remember in the slide where I showed you pathways that regulate eating, these are important regions that constitute this network that regulates eating. So our hypothesis was that those connections, if they're altered after recovery from anorexia nervosa, so maybe they tell us about alterations in the circuitry that might make it hard for somebody with anorexia nervosa to eat as somebody else would. In the right upper hand corner, you see these red, green, blue, pinkish pathways, and this is a real person who participated in the study, and you see how individually we can identify and look at these fiber paths. So I think that's quite remarkable. And in that study, we recruited 24 folks recovered from anorexia nervosa and the same number of healthy controls. Next slide. So what we found here is that the folks recovered from anorexia nervosa, they had higher connectivity strengths between regions, and the other aspect was that the higher connectivity between regions in the folks recovered from anorexia nervosa correlated with illness duration. So the longer those individuals had been ill, the more connections they had years after recovery when we studied them. So how we thought to explain that is or what probably the mechanism is that when you're ill, you may cause some damage to those white matter fibers, maybe reflected in this lower quality of fibers that we talked about. But maybe the body, the brain, makes more connections to make up for that. And in fact, there's precedence for that idea from the literature in dementia, where there's damage to the brain occurring, and then the brain tries to make up for it, trying to make more fibers to, normalize your brain again. And I think this is what's happening here as well. So the brain is making more fibers in folks who have long recovered. We also studied recently folks who had who were ill with anorexia nervosa and bulimia nervosa, and they also showed higher fiber amount, and on the other hand, not quite as strong as the folks recovered from anorexia nervosa. So, and that would make sense because while they're still ill, they make probably more fibers, but they have not been recovered. So, in the after recovered state, I would expect them more fiber regrowth, so to speak. Next slide. Let's look at effective connectivity. This is an indication which brain region drives another. So a hierarchy. This does not look at which brain regions act in sync, but rather which one controls another. Next slide. What we did here was we had folks taste sugar solution and did brain scanning while they were doing that. They were tasting and swallowing the sugar. And then we used a complex algorithm that then, based on timing and activation in those various regions, calculates what brain region drives another. Next slide. And this is what we found. And here's sort of one of the slides where it should be stepwise, which it isn't. So everything is already on the slide, so forgive me for that. What we found was that in the healthy controls, there's a so-called bottom-up control. That is, from the hypothalamus, there was information going, there was activity going to the striatum. And the hypothalamus is a really important part in the body that integrates how much sugar there is in your blood, whether you're hungry, whether you should eat, what your body temperature is, whether you're thirsty. So very important information about how the body is doing, and then takes it, so to speak, upstairs to higher order brain structures to then decide what to do, right? To eat, to drink, to cool yourself off, whatever. What we found in the folks with anorexia and bulimia nervosa was the opposite. There was a direction of activation from the cingulate cortex, which is important for decision making, error monitoring, to the ventral striatum, to the hypothalamus. So what we call this is a top-down control. So what we believe is happening, that you can override these homeostatic body signals. And I think it makes a lot of sense, and it goes very much along what we see clinically. Folks with an eating disorder, they often are hungry or do want to eat something, but they don't allow it. they don't allow themselves food, and I believe this is the circuitry that controls that controls letting these body signals tell you what to do, so to speak. Next slide. So let's look at brain function and behavior. Next slide. When we look at brain imaging and behavior, then we start the behavior, we try to relate regions to the behavior, then we try to put it all together. How do these brain regions act in sync? And then understand, hopefully, a mechanism, how this circuit activation drives behavior. Next slide. So when I think about eating disorders, I think it about as a regulatory problem. There's a problem how much drive you have to eat certain food versus what the body really needs. So the person with anorexia nervosa, she has very little motivation to eat, although her body would need much more, right? The person with bulimia nervosa sometimes restricts, but sometimes cannot help it. There is some motivation to eat large amounts of food, but then it feels very bad afterwards, and then she throws it up again. And when I say motivation, that doesn't mean conscious, volitional, doesn't mean where I have full control over. It means circuits in the brain that drive sort of an intrinsic motivation that could be very biologically driven, where we have actually a hard time to control it. And then there's, on the other hand, binge eating and obesity, where folks eat much more than their body really needs. And so there is some motivation that's unhealthy in relation to what the body probably needs. Next slide. So why I think motivation and reward are really good targets to study in eating disorders is, for one, on the left, you see these red and black arrows, and they reflect how much we know about these regions and how they act with each other. So there's a lot of basic science, animal research, where folks can open up the brain and look at specific pathways and neurons. So we know a lot about how these regions interact with each other. So how, let's say, the anterior cingulate, the frontal cortex, connects with things like the amygdala, the hippocampus. So these basal ganglia and more lower order regions in the brain. So we know a great deal about that. And it's really important, I think, that we use brain imaging in models where we know a lot from the animal literature, because then it's much easier, I think, to interpret what we find in the human. The other important aspect is why I think reward and motivation or drive are really good targets for study is that they have been associated with dopamine function. They've been associated with a particular neurotransmitter that is involved in drive and motivation, and we know a lot how the neuron, the dopamine neuron, acts under particular conditions. And I will show that in another slide. There are also other neurotransmitters involved, such as GABA, opioids, and so forth. But the problem is, with these other neurotransmitters, it's very hard for us to model them, to really know how do they act. The only neurotransmitter we really have a mathematical model for is dopamine. Next slide. So, all right. So this is maybe the most complex part of the talk, but I think it's really important because this gets into an area of brain research where things are going. This is an area of research that, or a direction of research that will be with us for a long time. It's called computational modeling. And it's actually really cool because you can really nicely relate it to real life behavior. And again, with slight transitions. Not sure, Bethany, there seems to be something off, but I'll just uh, work with it as it is. So let me tell you this. Let's say you have, no,
Sorry.
can you please go back?
Yeah, sorry.
So let's say you have a really friendly office mate, and that person puts a piece of cake on your desk on one day. Then you have an unexpected reward experience, let's say. And then you have a dopamine surge. So dopamine neuron acts. And then let's say this person is really nice and puts a piece of cake on your desk every Monday. Then you learn to associate the dopamine part with the cake with Monday. So when you get up on Monday, you think, oh, it's Monday, and you get a dopamine surge. And then when you go to your office and you get cake, there's actually no dopamine action happening anymore. However, when this really friendly person is ill one day and is not there in the office to bring you the cake, then you got up on Monday, you had the dopamine surge because you thought it's Monday. So the Monday becomes the conditioned stimulus that the dopamine responds to. And then you go to your office, there's no cake, and then you have a dip in dopamine activation. So a negative response, so to speak. And that was put together in a formula. And the formula is reward received minus reward expected equals the prediction error. So the prediction error is when there's a difference in what you thought would be happening versus what's actually happening. And that prediction error you can sort of calculate for an event or many events, and then you can correlate it with brain function. And this is a straightforward, simple form of computational modeling. So something that is promoted very much and will be more promoted because we need these more complicated models to understand the brain. Next slide. We can do this model in humans in the brain scanner. Folks are in a scanner, they have tubes in their mouth, and then they learn to associate pictures with taste. Let's say the purple one with sugar, the turquoise one with artificial saliva, and the orange one with nothing. And so in the condition when they expect nothing after the orange picture, they sometimes, in 20% of cases, they get sugar, creating the unexpected receipt of this rewarding, or let's call it salient stimulus, creating this positive prediction, positive dopamine surge. On the other hand, when they see the purple picture, where they think sugar will be coming, there will be in 20% of cases nothing coming. So you thought something would be coming, but then there's nothing, and then you have to dip, and you create again the negative prediction error here. And then you can calculate mathematically for each trial what prediction error there should be, positive, negative, none, and then you can regress that with brain function. And then you can look at how strongly do people respond to this model. How strongly do they respond, which would give us then an idea how sensitive is maybe this dopamine system. Next slide. So we studied this paradigm in folks who were ill with anorexia nervosa, then controls, also obese individuals. And what we found was that the group with anorexia nervosa had a much higher response compared to the controls and the folks with obesity. So quite nicely across various regions, very, very strong patterns. So higher responsiveness in those adults with anorexia nervosa. Next slide. We did a similar study in adolescents with anorexia nervosa that was just published before and after weight gain. And the blue columns are healthy controls. The green columns are folks with anorexia nervosa, and they're scan 1 and scan 2 that were about 6 weeks apart for the kids with anorexia nervosa before and after weight gain. And you see that across many of these regions, the green columns, so standing for the anorexia nervosa kids, they are higher compared to the blue ones. So the kids with anorexia nervosa, they similarly to the adults had an elevated responsiveness in this model that's anchored in the dopamine system. So a more sensitive responsiveness. Next slide. So now, what we found was that the discharge body mass index was negatively correlated with brain response when they were underweight, so at scan 1. So the higher the brain response was at scan 1 before treatment, the less body mass index went up during treatment. So it predicted in a way that how well treatment went, right? And when I say high brain response, then I kind of want to translate that into illness severity, right? Because the high response wasn't much higher than controls, maybe something like fever, right? Um, and then the other thing what we did is we looked at treatment length and BMI change. And the longer somebody's in treatment, the more BMI changes, right? So the longer they get help, so to speak, the more weight they will gain and body mass index changes. And you see this reflected nicely in this orange line that includes all the anorexia nervosa kids. But then we separated the ones who were more sick, and you see that in the blue circle here, pointing to the blue line. And the blue line is not significantly correlated anymore in this BMI change in treatment length, as opposed to the kids who had lower, that is more normal brain response, and there was then a quite strong correlation between BMI change and treatment length. So what I want to say with that, or how I interpret it with that, is the kids who have a more normal brain response, they respond quite nicely to our treatment regimen. The kids who have a very high brain response, who are much more sick and have a change in neurobiology, they did not respond so well to our approach. Posing the question whether those kids might need more or something different, something extra to help them in their path to recovery. So again, this prediction error brain response could be a measure for illness severity, and that could tell us about outcome of weight gain, for instance, and rate of weight gain. Next slide. So here's the overall concept how I put it together. And it's more dramatic when things come step by step on the slide, so it's all already there. So let's start with the dopamine system that is overactive in anorexia nervosa. You would say, rightfully so, that should drive eating stimulation. And I think that's what it does, because if somebody's losing weight, then the system says to gain weight. On the other hand, there is this terrible fear of gaining weight, right? Oh my God, there's nothing worse than eating equals getting fat. And I believe this becomes an irreconcilable conflict. I think this is part why those folks are stuck. And it's funny because when I was in my late teens, I read Freud and things like that before I got into CBT and all kinds of other things. But it reminds me of these Freudian conflicts. You have like two different drivers. They don't work together and they want to go in different directions. And then you're stuck. And I think from a neurobiological perspective and then this higher order cognitive emotional perspective, those two systems work in different directions and then make it really, really hard to, get better, to gain weight and normalize behavior. Next slide. So the question is, can we use this information for treatment development? Can we modify this hypothesized normal dopamine activity? We did start working towards that, and we published in iJet and other outlets papers on that. And we did recently a retrospective chart review where we showed that a dopamine medication, an agonist, partial agonist, seem to be helpful for weight gain in anorexia nervosa. You could say, well, if the system is hyper-responsive, hyperactive, you should be able to help it with an antagonist, right? And various antagonists have been applied. But the problem is, at least after a few weeks at the latest, after giving an antagonist, your brain makes more receptors. So you might just defeat the purpose. However, if you give an agonist, then at the low dose, that's important, you might gradually downregulate the system. That's why I think from a biological perspective, this makes sense. So this would be a direct result of the brain imaging that we now start to develop as a treatment and working towards a randomized controlled trial. Next slide. So in summary, next slide. Self-starvation, eating, purging, affect gray and white matter. An important message that I tell all my patients with eating disorders that they most likely have changed their brain and still change their brain. And that's, for some at least, the motivation to get better, because it may cause problems that might be difficult to reverse and might have an effect on how well you can think, experience things, and so forth. Changes in the orbital frontal cortex, insula, that we found across illness groups or eating disorder groups could be a risk factor, maybe premorbidly, maybe that becomes a risk factor during the illness, risk factor in terms of having a hard time recovering. Then there is a top-down control in the eating disorder folks that probably overrides the hypothalamus and bodily signals. The reason why I think this is important, aside from hopefully eventually being able to change those circuits for the better, I think we can use that very well in psychotherapy. And we can, with all this biological modeling, we can give people something to look at and understand why their brain works a certain way. And I think if you know about that, then it might be easier, or is easier in my experience, than to work on strategies to counteract that, to counterbalance that towards a better life. So that's what I use these things for all the time. So I draw a lot of pictures on my whiteboard in my office. And then there are these altered reward pathways, we think relating to the dopamine system, and they could become treatment targets, including medication. And next slide. So last slide, I just want to show you my model, how one might develop or maintain an eating disorder. And next slide. And so there's our little slide advancing issue. You see the lower parts not so clear. But I think in an overall model for developing an eating disorder, maybe predisposing traits, biology, I think, and from what I understand from literature, there's high anxiety, sensitivity to salient stimuli. There's maybe a difference in orbital frontal cortex part that has to be with satiety, and then maybe dopamine circuits that are unstable. Now, folks with anorexia nervosa, they usually show high cognitive control. But what I believe is that the hypothesis that I'm working on is, I think their dopamine system sensitizes more easily than other folks to food restriction. So when they don't eat as much, their system changes quickly to getting more sensitive. Folks with bulimia, they often also have high cognitive control, but their dopamine system might desensitize to excessive food. So when they eat large amounts of food, their system might get desensitized and changes in that direction. Binge eating disorder, folks have often less cognitive control, and their dopamine system also desensitizes to excessive food. And then during puberty, there is a lot of change in dopamine function happening. So the dopamine system gets quite activated when a girl especially gets into puberty. And then there's also times when there is food restriction. Let's say you go to camp, you eat less, you are in high school, you have times when you just don't get to eat. On the other hand, there are times when there's a lot of food around. And that then affects folks who are sensitive. So again, sensitive that their dopamine system either sensitizes or desensitizes. And then there are other things that may or may not be around, such as family function causing stress, poor self-esteem, social pressure, all these psychosocial parts that are really important, but that apply to some and not others. So that's where the differentiation between each individual comes in. And then I think it becomes a vicious cycle. Uh, Food restriction, anorexia nervosa leads maybe to a short-term reduction of a hypersensitive experience of the dopamine system, and they don't like eating because it overstimulates. So they want to restrict food more. In bulimia nervosa, cognition drives food restriction and purging, but because they have dopamine circuits that are desensitized, like in an addiction model, they need more food to get stimulation that drives binge eating. And in binge eating disorder, high food intake drives a desensitization of the dopamine circuits. They have a very hard time controlling that, leading more to craving and food intake. And if you folks are interested in, I'd be happy to email you the paper of this predisposing traits model, so you can read up, because this has been a complex model. And next slide. And yeah, so at the end, thank you very much for listening, and I'm very grateful and thankful to all my collaborators who have helped me in funding sources.
Well, great. Thank you, Dr. Frank, for that presentation. And so we'll be starting the question and answer portion now. So if anyone has any questions, please just type them into the chat box on the right, and I will pose them to Dr. Frank. Okay. So Christy asked, how is a recovered individual defined as seen throughout this presentation?
Thank you for that question. I did not put that in. The way how we have defined it is, and there are different ways to define it, is individuals who have been without binging, purging, major food restriction, have been at least have been at the normal body mass index for at least 1 year, for at least 1 year or more, that they would not meet diagnostic criteria and have been doing pretty well, so to speak.
And for everyone that's typed in their email, I will pass those on to Dr. Frank. And alternatively, you can also email me at bblackwell@aed.web.org, and I can also forward those on to him.
So, Bethany, should I just email you the paper, or?
Yeah, that would probably be easiest, and that way I can share it with whomever
Yeah.
requests it.
And if you have any questions down the road, folks, please don't hesitate. Feel free to let me know. So I'd be more than happy to respond to any questions that you may have come up or whatnot. So anytime, please.
Okay, are there any additional questions for Dr. Frank? Oh, Margaret asked, are there clinical signs to watch for when brain scanning is not available with anorexia?
So, I mean, the truth is, brain scanning is a research tool at this point in terms of eating disorders. I'm hoping that it will become a tool to predict recovery, a tool to help us understand and develop better treatments. But at this point, it's not a reflection of severity of illness at this point. On the other hand, what's also clear is this brain imaging is complicated and costly and stuff like that. And what I'm working towards is coming up with methods using clinical science and using behavior measures and things like that as a reflection of the brain, of structure, of function, so that, this is really my hope, my true hope, that you in your private practice, that you then can measure certain things in your private practice and then get a reflection of the brain, what the brain actually is doing and what it's like. So this is really my hope. So in terms of clinical science, um, there is, you have to go with what you probably already are doing, you know, but a really important part, and we all know that, is the body mass index. So the body mass index tells you, of course, about severity, and it's in part a reflection what the brain is like, but there's also a lot missing, you know. So it's an important indicator, but it's not a total. In terms of signs and what to look out for, I think we as a field, it'll be really important that we all speak the same language and that we all use validated assessments and so forth, that will help us then, that all of us assess our patients in a way that uh, that we apply then the most effective and individualized treatment for. So I'm not sure exactly if that exactly answers your questions. If not, please let me know.
Okay, and Audra asked, are there any medications on the market today that would be close, sorry,
Most
scanning.
effective for treatment based on today's presentation.
Yes.
So, so here's the thing. I strongly believe in a medication, but I also don't want to oversell it. So I want to be cautious. But you saw I published in iJet on a medication called Abilify. And based on our research, I started using that with the idea of down-regulating the medication, the brain response. I told you I'm a therapist at my heart, and I don't think we will ever have a medication that will cure anorexia or that will cure bulimia. But I'm very convinced that we will have medication that helps in this process, and especially that makes people ready for psychotherapy, makes them more able to take advantage what therapists offer, which is key. Now, with the Abilify, uh, at low dosages, and I usually, at the kids, I may start a milligram twice a day, for instance, or maybe even a milligram once a day. I usually don't go up when they're underweight. I usually don't go higher than 2.5 milligrams twice a day, because then at higher dosages, the medication effects, they also change in certain ways. But that seems to have quite a beneficial effect. And there's various responses that you get. Some kids tell you the next day, I just feel less anxious around food. Other things are that the therapist, and that's really most rewarding, they ask me often, can you please put her on Abilify? Because they see the benefit of them being cognitively more flexible in a way, more able um, to take in what they hear. And I sometimes compare it like you're sort of underwater, you're floating when you have the illness, but the medication hopefully gets your head over the water, so you can get a view what's really happening here. So the Abilify is something I strongly or work with a lot. I think it's helpful, but as long as we don't have a randomized controlled trial, I want to be cautious. But I do hear it's sort of it's used now everywhere after we published that. So
And so Elena asked, what do you think, sorry,
about MRI
I
spectroscopy
just
and
started
you
eating
first.
disorder, yes.
So that's a very interesting modality, and MRI spectroscopy gives you an idea about how much of a certain neurotransmitter is in a certain area of the brain. So, for instance, GABA or glutamate or glutamine levels in a particular section of the brain. So I think it's very interesting, but it also has its limitations. One problem is that you have to limit your area of investigation to a certain uh, smaller region, because otherwise it takes too long the study. Um, and we have experimented or piloted research in that direction, but I wasn't really sure if it was, you know, I didn't see anything striking to come out of it so far. But that could also be because maybe we were not in the right region, and maybe we have to change our, you know, how exactly we study that with MRI. So in general, I think it's a very interesting modality. It gives us a measure of brain chemicals, which is fantastic, but it's still tricky.
Okay, and Katie asked, have you found significant structural or functional changes in regards to ARFID?
So I have to admit, I have not really studied ARFID. I have not done that yet. Maybe I will be getting into that. I know that some people in Boston are doing that now. I know some people in San Diego are studying ARFID. Um, there is an article coming out in iChat, uh, probably relatively soon, that studied RFID to some degree, and they did not find, is my recollection, but don't quote me on that, but my recollection is they did not find changes similar to anorexia nervosa. So that would speak, although they are maybe getting at the lower weight and stuff like that, it's not quite the same. But it's about as far as I can go and say. But I think RFID is an entirely understudied area, so I think there will be a lot to come still.
Okay, and are there any additional questions?
So as I said, if anything comes up, I'd be most happy to respond to any email you send me if you have any questions down the road. Thank you all for your attendance. I really appreciate it.
Well, thank you again, Dr. Frank. And just as a reminder to everyone, our next webinar is scheduled for November 16th with Dr. Cameron Eddy, and she will be discussing the topic of recovering and eating disorders. So you can find out more about this and other webinars by visiting our website, aedweb.org, and clicking on the Education tab. So thank you everyone for participating and enjoy the rest of your day.
Thank you. Bye-bye.